Outpatient Clinic and Bedside Teaching, an art and a science, and over to Dr. Grover.
This is not what I connected.
We've asked him to keep it on for about seconds.
It's a wonderful initiative that OFAC and AIOS planned this joint program, because OFAC has been doing such a wonderful work. It's a joy to be a part of that initiative, and it's good that we in India are being exposed to the work that they're doing so that we can take more benefit of the initiatives that they are taking. It's worth visiting their website and the work that has been done so far. I think it has already been introduced to this audience. Thank you, Meenakshi, for making me a part of this program. Thank you all for being here. Great to have such a wonderful audience with people who are such great devotees of ophthalmic education, I would say, more than anything else. So, outpatient clinic and bedside teaching. So, in reality, we're talking about clinical teaching, which we all imbibed as an art and imparted as teachers as an art, but the science behind it is also immense. In fact, what happened was, when I was in Guru Nanak Eye Center, I started teaching in the faculty. When I was completing 8 years and leaving for Gangaram, that was the time when I attended my first workshop on ophthalmic education after 8 years and got an idea that there was a science. So you imbibe so many things by your day-to-day experiences and your impulses, and then when it is put in an organized way, in a thought-out way, it makes so much more sense. So we need to know it both as an art and a science. So as Osler said, to study the phenomenon of disease without books is to sail an uncharted sea, but to study books without patients is not to go to sea at all. So clinical teaching is really the core if we are to train clinicians and surgeons. So bedside teaching or clinical teaching is an integral part for developing what is our objective of giving evidence-based medicine to our patients. So we are going to discuss why should we teach at the bedside or in the clinic, what are the positives, and let's look at the negatives also. Let's look at the constraints. How do we carry out clinical teaching? What is the methodology that we can follow for it to be more effective? What we should do and what we should not do in clinical teaching, how to assess the learners, and how to give them feedback for us to be more effective in clinical teaching. So teaching on the bedside is important because it's the most effective modality, and clinical skills obviously can only be transferred by clinical teaching. No theoretical training can do anything to impart clinical skills. And then, most importantly, the professionalism and role modeling of skills and attitudes are learnt in clinical settings only, and communication skills are also seen and developed during those sessions. So it is the right kind of context, the kind of context that you need to have, because that is the real life scenario that they're going to have. They're going to see patients. So that is what is important. And he's using all his senses at that time when he has to do observation, palpation, and think about it, use all his senses in order to have a clinical decision making. And therefore, it also creates a much better recall in him because he's using all his senses, and it also increases his motivation because he's in a real setting. He's seeing the benefit, so he's much more involved. So that is the important, he/she. So what is achieved is that when they see an experienced clinician handle a patient, they know how to approach an individual or a human being or a patient as a human being, take him holistically and not just the symptoms or the signs. It also allows the clinician to observe the student's skills, his method of examination, and correct him too. So if we were to summarize it, it integrates clinical, communication, ethical, problem solving, and decision making skills. So all those skills are only coming into play when we do a clinical teaching. Now, the shortcomings are that it's fairly time consuming. It's much easier to download from AI, as Prashant said. He'll get a good, put in all the data and get a good account of differential diagnosis. But clinical teaching would take much more time. And there is also the question of privacy of patient and troubling him, or 5 people palpating him or examining him, and so on and so forth. So therefore, there are constraints. One is that clinicians are busy people who have a lot of work to do, clinicians, surgeons, so there are time constraints to it. And sometimes preceptor thinks that he's going to achieve a lot more, or he's inexperienced enough not to know what to do, what not to do. He may also have false concerns about patient being inconvenienced, or at least exaggerated concerns, let's say. And this has been touched upon by Prashant again, that learners these days think they have a lot of material available from elsewhere, digitally elsewhere, so they get often distracted. They look up things then rather than listening at that moment. So to promote teaching in the clinic, it is important to make sure that patient is comfortable, because that is an integral part. Unless that happens, you would probably not be effective in teaching. Have a professional approach to make patients' comfort better, make him aware that this is being done and that these are students and that this is what they're going to do. Not do anything which will be possibly be too troublesome to him, but at the same time, do not have exaggerated concerns about patient's comfort or talking in front of him. But how should we go about this exercise for it to be most productive? We should plan it well. Exactly think about what is the objective that is planned for that particular session. Allocate time for it. If you don't allocate time for it, you would probably never get down to it. We should think about how we are going to go about it, structure it well, and make sure what you are doing is a part of what we want to impart. It is a part of the curriculum. And we must at the same time assess, and as we'll say later, give a feedback which is effective, which tells the person how to improve with what we have assessed. So make a focus plan of what you want to achieve for a particular encounter, and put a greater emphasis on that part. Say if you think that you're going to emphasize more on history taking that day, spend more time on that to make sure that that is what is emphasized on that day, or a physical examination or patient counseling or breaking bad news, because you can't do everything in one such structured clinical program by a clinician. So we'll go through the components of clinical teaching. Art of history taking is very important, and this is what all clinicians know, that you are down to a differential diagnosis of maybe 3-4 small entities after you've seen the patient, heard him, taken his history, known his age, sex, and the concerns, how they are expressed. All those things, inputs are important, and you're left with very few things to focus on in your examination often. And then the skills of clinical examination. This obviously is so important. Proper technique of examination, being able to pick up the signs. They need to be shown those signs so that they can are able to pick them up, because as we know, you only see what you know. So interpret the signs to make a differential diagnosis, analyze them well to think up a sequence of events, and make a plan of action. These are the usual things we say, but it is important to build that thought process in them. And then learner can be observed in the process of clinical examination and corrected, as we said, which is only possible in a clinical setting. And this cannot be overemphasized, even though it is being repeated. Communication, courtesy is what needs to be learned, and this affective domain, compassion, empathy, this can only come if they have a real life experience of this being done, and that's where a role model comes in. So a role model not just needs to have clinical knowledge, clinical skills, clinical art of history taking, he needs to have personal qualities and the teaching skills. He should know, he should be able to impart them, and he should be a role model in the real sense. Okay, so, but what we do need to avoid is being critical of the student, critical of to be done in front of patient, because that gives a bad taste to the student and to the patient as well. So that negative message must be avoided, and things you can give that kind of a feedback if required separately. So a negative feedback, arguments, angry tone, and criticism must be avoided in clinical teaching. Now, different models have been spoken about. For the younger of the early learners, the model of sitting in, where the students are with the preceptor and they observe what is being done, or then they can break out into, with the patient, come back with the feedback, report back model, that they go to different parts with the patient and then come back, or apprenticeship or parallel consultation model, where they are doing a parallel consultation but taking a feedback at the end where required from the preceptor. So the last two parts are feedback and assessment. So one is that at the end of the session, you can ask the learner to look back at what happened, what the encounter was like, and what he felt were the positives and the negatives. And make a direct observation, but try and make the feedback in a few focused areas. Don't be too general. If you give a very general feedback, if you say you are bad or you're not good or you made a mess of it, it doesn't help. So if you're more specific on what went well, what needs improvement, and be constructive, then you are able to get a much better output. So there are a number of methods for formative assessment, which you do direct observation. O6 is one useful way of doing it, which is relatively objective. Case-based discussions, formative OSCE, objectively structured clinical examination, and feedback from different sources about a person's clinical behavior, from nurses, from the other staff involved. So O6 was an objective tool given to assess patient care skills, medical knowledge, as well as the interpersonal skills. And this is how it works. You have the interview skill, examination, interpersonal skills, and case presentation part of it, with different parameters assessed in a scale. And we in the national curriculum tried to simplify it for Indian conditions, make it simpler, use lesser number of parameters so that it could be used more often in the day-to-day feedback. And we had put this down in the Medical Council of India recommendation as an internal committee for MCI to adopt it. But unfortunately, that board of governors got dismissed soon after, so it never became a part of the curriculum. So to conclude, I think this needs no emphasis at all, that clinical teaching forms the backbone of all clinical learning, and we must all go through that whole gamut of it. And there are no shortcuts to it. No AI will tell you, or no other source of information will tell you. You will not get the wisdom by any shortcuts of getting the information. So effective understanding of the clinical teaching as a modality and using it effectively is critical to making it a useful tool. Thank you all.